Hey there, friends and scholars. We're so glad that you joined us tonight, and we're going to have a growing group over the next hour and a half to participate in our IDM study club. This has been so exciting, and we've got some very exciting things to share with you. And Tom and Laura and Gina are with us, so say hi, guys.
Hello, everyone.
Welcome.
We're going to be talking quite a bit tonight. In fact, the emphasis of our discussion tonight is going to be on the inflammation infection piece, particularly the oral component of that. And so we're going to have a quite a lengthy discussion on that. Hey, Mike McDivitt, how you doing, buddy? Good to see you. And so many others. We want to share with you, though, that there is a lot going on with IDM Scholar Society these days. And I want to tell you a little story just to show you how things fall together. I have a nephew named Christopher Stadler, and he has served as the marketing director at Procter & Gamble after he graduated from Duke University and did a MBA at University of Michigan. He worked with Procter & Gamble, and he was in charge of all the advertisements and commercials for Cheer detergent. Then he went with a large company that did fitness centers in major cities. It was very upscale. Then he was the marketing vice president of Ironman triathlons, and they took it from about $100 million to over $1 billion a year in revenue. And then most recently, he's been the marketing vice president of Tonal, which you've seen on television, which is an at-home fitness piece of equipment. And LeBron James is their face on the commercials, along with one of the Williams sisters. And so Christopher has had quite a marketing career. So we were sharing with him as we met with him last week about our goals and trying to revolutionize healthcare through dental medicine and working with our medical colleagues to really try to turn things around, especially with the pandemic of inflammation that we know is the driver of most of the things that we are experiencing. So we spent about 30 minutes sharing with Christopher about what we were about, what our goals were, what we were hoping to see, what we were wishing and hoping things would look like in 2 or 3 years if it was the best it could be. And after 30 minutes of listening, he said, well, I've got about 10 ideas for you. And he started going through one by one and really turned us upside down in a very exciting way of really clarifying our vision for what we want to do together with you and what we want to do for the country and for dentistry and for healthcare. And so we'll talk about that a little bit tonight, but just as an introduction, 2 things that we're going to be speaking to you about going forward is one, creating a fellowship program for you to participate in, where at the end of going through a series of classes that we're putting together now and almost have completed at this point, then you would receive an IDM Scholar Society fellowship status. And we would do awards at our annual symposium. But the other thing that came out of our conversation with Christopher was the idea of creating coaches, health coaches. And so we have clarified that now as far as what that would look like to develop integrative medicine health coaching programs for you to participate in, if that was something that was your desire. And so we're very excited because we feel like this really focuses and zeroes us in on what we're all together all about. And so we'll share more with you about that later in the evening. But right now, what I'd like to do is to turn it over to Gina and Laura and Tom to talk to you about this inflammation infection model and some of the things that they're doing right now in their practices and in the research that they're part of. And so, Tom, I know that you had some great information that you wanted to share with the group tonight that's hot off the press and something that you felt was very relevant for our conversation tonight. So take it away.
Well, thank you, Whit, for the introduction, and welcome everybody to our conversation. This is a little bit off the cuff, but it does certainly open some doors for me to share with you of some of the work that I've been doing, looking at research and how we can improve our services and how we can co-manage patients. When we look at, and we have to ask questions. I think a good clinician always is asking the right questions, because we observe not only the conditions that we see, but we can also observe the end point of the treatment that we are providing for our patients. And one of the questions that I've been asking for a long time with periodontal disease is, what is the really, let's say, published end point of periodontal therapy? And I wondered if I were to ask that question, what the answers would be, and if any of us really know what we're trying to achieve. Now, the reason I asked that question is because the most of the dental literature really, and periodontal literature really relates to the endpoint of periodontal therapy relative to tooth survival or teeth survival. And almost none of the periodontal literature, there are some exceptions, but almost none relate to the endpoint of periodontal therapy relative to two other areas. And so I call this, and I'll kind of take this from Whit and from Laura and from Gina on the IDM, the pillars. I think there are three pillars now of periodontal disease diagnosis and periodontal disease endpoint of therapy. Number one is the clinical, and that is, what is the clinical, or what are the endpoints of clinical periodontal therapy? But the other two we rarely see in the dental literature, but we do see in the medical literature, and that is, what is the microbiological endpoint of periodontal therapy? In other words, how do we help control the microbiome? And then the third would be immunological. How are we affecting the immune system with this infection that we are trying to resolve? And those two are more critical than the first one. Of course, we are taught as our primary objective, and that is to help people keep their teeth for a lifetime. That's a very noble service. But what we have recognized in this collaborative effort and in the literature reviews is that many authors in the medical literature and a few in the periodontal literature have suggested, and I'll give some examples. As an example, Colombo's clinical trial in 2012, looking at scaling and root planing and surgery for those pockets greater than 6 millimeters, found that at the end of 16 months, they had about a 36% failure rate. In other words, they had progression of disease because all they were doing was scaling and root planing and surgery. They were not doing any adjunct except antibiotics one time for those that had greater than 6 millimeter pocket. But there was no maintenance other than brushing and flossing and then 3-month recare. And so with that model, at the end of 15 months, 36% of the patients that were treated by trained periodontists, both in the initial visit and the surgery visits, over 1/3 of them had progressive disease. And Colombo and his group came up with the basis for that. And the reason it is because they were actually using microbial testing. And they said the reason that people continued to lose alveolar bone is because of microbiological instability. That's what we've been saying for years now, is that we have to measure what we know today about the microbiological content of the oral microbiome. We're still learning a lot more about that, and you'll see later on this year some shifts more toward the healthy microbiome. But the point being, we have those that are admitting that when there's microbiological instability, people are going to fail. And the other is, as Offenbacher said way back in 2010, one of our goals of periodontal treatment is to make sure that the mouth is not a source of systemic inflammation. And so today we could use that term, but I think even a more impressive term, a more meaningful term would be, how are we affecting our patient's immune system at the end of treatment? And can we measure that? And can we measure all three of those? Because if we can't measure it, we really don't know. So can we measure clinical endpoint of periodontal disease? Well, we can. And what is the we know how to do that. That's what we're trained to do. But if you look at the literature, and here's one that's called The Endpoints of Active Periodontal Therapy. And this was published in 2020 Journal of Clinical Periodontology, and well accepted in the periodontal community relative to what is successful periodontal therapy. And the endpoint, in looking at 94 articles from the year 1946 to the year 2019 relative to survival, meaning that's the goal of periodontal therapy only in these articles. They basically say that if you have less than 30% of bleeding sites and no pockets greater than 4 millimeters, that you can save teeth for a lifetime. But what they're saying is you can still save teeth, but 1/3 of the patient's mouth is still infected. Think about that. Is there any other infection in the world that we would want to say that that's our endpoint? I see Mike, shaking his head there, but that's where we are in the year 2020 relative to the endpoint of periodontal therapy, and we're trying to move into the oral systemic world. And if we don't recognize the microbiological shifts and we don't recognize the immunological shifts, when we have 30% infection, I would suggest to us that we are not achieving the other two endpoints that we need to achieve. And the question is, can we measure those other two before and after? Well, microbiological, you all know me, that I've been kind of on that soapbox now for almost 25 years, actually longer than that, but with using DNA, at least 25 years. But the point I make is that if we aren't testing, there's no way to measure that. We don't know when our patients are safe if we don't test before and after. That's simple. And it's easy to understand. But if we go to Gina's office or other physicians that can help us with Cleveland Heart Lab reports, I think now that coming from Quest, but you all know when I talk about Cleveland Heart Lab, we can measure all of those areas of arterial inflammation that are so relative to this conversation. And so if we really want to co-manage patients, I suggest to us that we have to have this 3 pillars of periodontal diagnosis and treatment, just like we have the 4 pillars of the IDM. And that's the reason that the story of infectious inflammatory periodontal disease is so important. Some other literature that I've run across, and it's an area that I've been looking at for a long time, is the subject of oral dysbiosis and autoimmunity. For over 50 years, we've spent a lot of research time in the world of periodontology looking at periodontal disease as an autoimmune disease, or at least as a disease that has autoimmune characteristics. And we all know that that is true. The loss of alveolar bone is due to a dysfunctional immune system. We've turned on the osteoclast rather than the osteoblast, and the osteoclastic activity continues 24/7 when a patient is infected. And there's some great articles on that. I'll put this online so that Kim can give that to us. But this one is called Oral Dysbiosis and Autoimmunity: From Local Periodontal Responses to an Imbalanced Systemic Immunity. And this is a review that's published in 2020 from Frontiers of Immunology. Frontiers of Immunology have given us more background today relative to this whole story than any other research group that I'm aware of. And I love what they publish relative to the state of the art in understanding the oral microbiome and the concept of autoimmunity. I'm not going to go through this paper, but I would love for each one of you to have the curiosity to go back and look at this, because it all refers to a dysbiotic oral microbiome which you are all very much aware of. And on that same note, I have a new book that's called The Tiger Protocol. The Tiger Protocol, written by a physician, Akil Palanisamy. I cannot pronounce that perfect, but this is a great book because his focus is on the ability to treat and heal your autoimmunity. And he has one chapter here on infections that are very, very appropriate to this conversation. And I know all of you are very interested in new literature that relates to this conversation. And he does have a paper that he recently wrote that really deals with the oral microbiome. And in this paper, I'll put this on this too, it's called The Oral Microbiome and Autoimmunity. So thank goodness we have people like that are recognizing that these keystone pathogens that you can test for not only create the instant response of that we call the innate that is unique to these pathogens, but also create an adaptive response that turns on the IL-17 inflammatory pathway, which is the one that's turned on in autoimmunity. All autoimmune diseases are affected by the IL-17 inflammatory pathway. And so it does connect everything that we're talking about. One other book I want to make you reference to, I bought this one in 2019. And the reason that I did is because it helped me understand more about the immune system. And what I mean by that, you think of the innate and you think of the adaptive, but this book is by Dr. William Lee, and it's called Eat to Beat Disease. Eat to Beat Disease. And what I learned from this is part one is called Hardwired for Health, Our Body's Natural Defense Systems. You don't have to, you can write this down or I can put it online or whatever. I'm just going to reference this. Chapter one is angiogenesis. In other words, hardwired for health, our body's natural defense systems. So what are our body's natural defense systems? Well, we think of immune system, right? But he is saying that all of these are part of our immune system. Angiogenesis, in other words, the production of new blood vessels. Regeneration, in other words, the ability for our body to regenerate lost tissue. Microbiome, which, that's our deal. DNA protection and immunity. So the last thing there is our immune system. All four of those others, though he says, are directly connected to our natural defense systems that he calls Hardwired for Health. I love this book. And what I did back in 2019, I went back and looked at Brad and Amy's model of preventing heart attacks and strokes. And I said, let's take each one of these. And I presented this at AOS in 2019. Each one of these, autoimmunity, regeneration, immunity, and all the rest of them. And I said, I wonder if the Bale-Denis method actually positively affects all of these areas. You hear what I'm saying when I say that? Is it possible that they have created a method that not only prevents heart attacks and strokes, but actually also refurbishes or defends or reestablishes a normal defensive system that includes all five of those areas? And I'm convinced that their model does that. I know Gina uses their model as well as other models that she uses as well. But Gina, just from your perspective there, I think that's an interesting perspective to assume that we have a model that not only prevents heart attacks and strokes, but also refurbishes all of these particles of our immune system, which also protects us from so many of these other immune-related diseases. So with that, I just kind of wanted to give you a short overview of some of the things I'm reading and preparing. At AOSH, I'm going to do a short 1-hour presentation on all of this and some new studies and new studies relative to all-cause death, a 50-year trial that was done on those that had served in the armed services, and it started in 1961 and just finished it. Basically says periodontal disease is based on all-cause death, a significant contributor to all-cause death. There's another one, a 35-year-old trial that relates to endpoint of periodontal therapy. Let me put it this way. the article says basically, does unsuccessful periodontal treatment increase the risk for type 2 diabetes? You hear what I'm saying? So we do all of these things that we try really hard to get a successful outcome for treating periodontal disease, and the periodontal community is saying, yeah, if you have 30% bleeding, that's okay. We can save teeth. But this article says that if you have you need less than 20% bleeding, or your patient is at a 37% likelihood of developing type 2 diabetes, irregardless of all other risk factors. Does that make sense to you? You see what I'm saying? Our goals and our endpoints for periodontal treatment for saving teeth are less rigid than the goals for helping individuals to prevent type 2 diabetes. The same thing is true for also heart attack and stroke, and also heart failure. And all of these research papers I'm going to present at AOS to give you all the details. But I just wanted to say that the IDM community is here to bring new literature available to us that we can not only attempt to prove our services, but also have new goals. So I want to end up by saying that let's be aware of our clinical goals, our microbiological goals, and also our immunological goals. And every time we see a patient, let's make sure that we measure all three of those and that we co-manage these patients so that we can end up with goals. So we can be assured that what we are doing does not put our patients at risk. In other words, that for type 2 diabetes or for all these other maladies that I made reference to here. So thank all of you for being here. And this is kind of off the cuff for me tonight, but I just wanted to share a little bit of that with you. So thank you.
Thank you so much, Tom, for sharing that, because it does bring up perfectly the discussion around what we wanted to talk about tonight, which is a more in-depth discussion of this oral systemic integration, if you will. And you've just, of course, set that up beautifully. But I do want to address just a couple of things that you said when you're talking about new targets, and I believe you said new goals and new measurements. That's one of the areas that I think is more exciting than I mean, every year that just gets more and more exciting, and especially now that we have the artificial intelligence software analyses to look at the intima media layer in the artery wall, because we know inflammation, the immune system response, as well as oxidative stress are all involved in this dynamic process occurring in the wall of the artery. So as you've just said, someone may look beautiful from a clinical standpoint, orally and otherwise, but we have several different ways we can look at downstream inflammation and infection and oxidative stress and immunity. The other thing, and this fits in nicely with one of the questions we got tonight, which was how can we definitively test for anything leaky as dentists and then know how we test for resolution? Well, y'all can talk about that as it relates to this area, but I would say that it ties in beautifully with the GI testing. One of my favorite GI tests, there's several great companies out there, but Vibrant offers what is, I think, mistitled the wheat zoomer, because most people think, well, that's to see if I have celiac disease or if I respond to wheat inappropriately or have an allergy to wheat. And it does that as well. It was one of the first tests they came out with, and that's what they've named it, so it'll stick with that. But it's one of the best tests at evaluating where someone stands in terms of intestinal permeability or intestinal leakiness, if you will. And we know, of course, if we're still seeing that, then we're going to go upstream and determine, okay, are we missing some microbial challenge that we're swallowing? Is that playing a role? Or have we just allowed other types of toxins in? Is it a problem with the immune system response? The list of questions goes on and on. But to answer that question, as well as one you've raised, is that's another great test to actually look for immune response and intestinal permeability and leakiness. And then we do have more and more artificial intelligence. For example, the test that you had, Tom, that you talked to us about at the inaugural Foundations, or maybe it was at Infection and Inflammation Workshop. I believe it was when you're on video, is the True Diagnostic Epigenetics test, because that factors in so many variables that the human mind could not evaluate without the use of artificial intelligence to determine what is someone's pace of aging. And of course, the immune system and inflammation and oxidative stress is involved in all of that. So I think it's a wonderful discussion that you've started tonight. I love the science that you delivered to us and your perspective. And I would love for us to have another study club, perhaps just devoted to this topic or one aspect of this topic moving forward. So Laura and Whit, anything else to add before we, or any other questions before we move on to kind of the next step?
No, I think not. Why don't you go ahead and share with them some of the things you all are doing in your practice? I think that'd be really helpful.
Laura, if you don't mind to share the slides, I think that also what you wanted us to talk about next, Whit, does indicate exactly what Dr. Neighbors was talking about just now, as well as we showed this Venn diagram of the integration between oral specialists and any type of systemic specialist. So of course, when we come together to integrate our practices to try to improve the overall health, the longevity, reduce risk, prevent disease, improve health optimization in our patients, anyone on the dental side, whatever their role, comes to it with an oral specialty perspective, knowing it's affecting the systemic, the entire complex human system, if you will. And then, of course, regardless of primary care physician, generalist, internist, or pediatrician, or women's health specialist, or whatever the focus is in the medical community, when they're integrating with the dental community, of course, come with this area of expertise in the system that is outside of the oral airway area, of course, looking to what is this, we used to say, and sometimes we still say, this bi-directional relationship, but I really see it more as a circular relationship in this entire human complex system. But as we move forward in trying to help everyone, ourselves included, improve use of artificial intelligence and use of our understanding of the current science and drive the science forward, we focus on this crossover. And this is a very short list of the crossover, but it is what Laura and I are seeing at the Prevent Clinic in practice as we integrate with our dental colleagues all across the country. The inflammatory markers, and I didn't even mention some of what we just talked about previously just now, but the standard ones that you mentioned, the Cleveland Heart Lab or the Boston Heart Diagnostics Labs tests, these have been around for some time now. And of course, we can understand inflammation with the myeloperoxidase and plaque tubes, specifically arterial wall inflammation, that dynamic process that's occurring that's leading to plaque, or is leading to the development of and the vulnerable nature of the plaque, as opposed to reversing cardiovascular disease or vascular disease anywhere in the body. ADMA is another great blood test, as that asymmetric dimethylarginine indicates, if it's above 100, that there is indeed an impairment in the nitric oxide pathway. We think of nasal breathing, we think of diet, we think of what's this individual's age. And just in case I forget to say it moving forward, Laura, feel free to jump in. But, you know, we had a discussion on Facebook recently, and I don't know if the person that started it, it was a great post where she was saying, hey, I don't know what to think about these nitric oxide saliva strips, because I've taken this product and that product and another product, and I'm still depleted. And a lot of people chimed in, and I did as well. But I just want to say that we need better measures for that. And I don't know that we'll ever have one, because as we all remember, nitric oxide is a gas that is really not available for very long, and it is hard to capture. So I just wanted to say, in talking about the nitric oxide pathway, that kind of Laura and I are now just, everyone age 40 and over is inefficient at the nitric oxide pathway. And you add in any airway disorder or any excessive mouth breathing and lack of nasal breathing and a poor diet, well, that includes almost everyone. And so we all need nitric oxide support. Let's just accept that. And I honestly think that those saliva strips, just my opinion, almost add more frustration for the patients, because they so badly want it to get darker pink, darker red. Let's get more. And you just can't get it there a lot of times. But we see, again, talking about targets, Dr. Neighbors, we see blood pressure lowering, we see sexual performance improve, we see cognitive function improve. One of the biggest benefits I see once we're repleting nitric oxide is stamina and endurance and strength with workouts or just with normal activities. So anyway, these are just some tests. We've talked about cone beam. We've talked about metabolic health, hemoglobin A1C, the sleep test, saliva test, and then of course the CIMT, or even better now, the CAT scan with artificial intelligence and with something called fractional flow reserve to determine when a lesion looks iffy, is it actually needing some intervention, or do we have time to work together, the dental and medical colleagues, to reverse and stabilize cardiovascular disease? That's a very exciting area. And the nitric oxide test, I don't know, Laura, we'll probably take that off before the next time. But what else do you want to say about this topic, Laura, before we move on?
No, I just want everyone to kind of understand, like, globally, these markers, right? We're talking about oral and systemic integration. The system we're calling OASIS, that you're going to hear more and more about, is really like understanding these basic, we call crossover tests. What do they mean for us dentally? What do they mean for us medically? And that we can understand that, I could say, like, almost in a one-liner. You don't have to know everything about it. Just know where they cross over. That little bit is just going to be more and more important. That's really what we want to guide you and teach you how to be able to integrate that every day into your practice. So with that said, we do want to share a couple cases with you here. And this was one that we just recently, we're talking about. You guys brought up the Cleveland Heart Lab. So walk us through. This is actually just a profound case for you, Dr. Gina, in a very short period of time. So
Yes.
we can see what happened.
Yes. So this patient, I want you to see that the lab results on the right, the way that the Cleveland Heart Lab shows chronological tests. The column on the right obviously is the before. So that was baseline testing. And then we checked 90 days later on the left, just at a bird's eye view. I want everyone to appreciate there is marked reduction in red, and there's more green. So we know things got better. Even if you don't know what all of these tests mean, or don't have even a one-liner like Laura was talking about, you can see, okay, if we're talking about the patient and you're telling me everything that's going on in the dental office and I'm telling you everything that's going on in the medical office, we know we're making some headway, so we can celebrate what's going well and what needs improvement. But for this person, we did put them on the GI protocol that you've heard many of us talk about. We did not do the GI testing. I wish in retrospect that we had that at baseline, and then we can do a follow-up to see if intestinal permeability got better. And also that test I was talking about earlier does show us some immune system response, at least GI related, which we know that's where a great deal of our immunity lies, with a look at lipopolysaccharides, et cetera. But anyway, I digress. So the GI protocol we put this person on, we put them on changes in nutrition and lifestyle, as you might suggest. We have this formula called the BLESSED formula, which stands for breathe, love, eat, sleep, stress, and exercise. And then D is diagnose for our testing. So we put them on every aspect of improving their lifestyle, the appropriate supplements based on the lab work that we had. We put them on nitric oxide support, as well as aspirin therapy and a low-dose statin, because of evidence we had testing showing of the presence of vascular disease. So in a short period of time, this got markedly better. So I just want, a lot of times people say, you just really can't get improvements in blood work. Forget how fast it occurred, but just that a lot of people out there, there's a myth, Dr. Neighbors, that you can't really clear tests and you can't really improve blood work. And Laura and I just tell our patients we've left some stone unturned. If we're not getting, this person still has several things that we're still working on, obviously, because we want that plaque too, that second test that is indicative of inflammation in the wall of an artery somewhere. We want that to come on down to normal. And so we still have things to work on with this patient. We wanted to show this as an indication that labs can get markedly improved very quickly with just these basic interventions on the left.
Can I add something there, Gina?
Yes.
Okay, thank you. I'm looking at the questions while you were giving all that great information there, and it kind of really tied into what I was talking about in a very, very real way. One of the concerns and questions in our chat was how does testing for oral specific. In other words, the question started with the statement that basically we treat clinical signs of disease. How does testing change what we do? And basically, I guess the question is testing worth the effort? And so let's put it this way. If our goals of periodontal treatment are only designed to save teeth, then we don't need to be associated with this subject. We should just leave and say, well, we're doing all we need to do. We're saving teeth. But we're all here for a different purpose. And that purpose is to improve the service that we provide to our patients. And learning how to use a diagnostic test is a process. And learning how to use Cleveland Heart Lab or Boston Lab or Quest. And the point I want to make is, please, anybody that has that question, I put my email out there on the chat. Please contact me and let us help you with that. I can just say from my own experience, treating hundreds of patients and seeing thousands of result reports, that what we are doing in periodontal therapy today is not sufficient enough to protect our patients from type 2 diabetes and cardiovascular disease and dementia and the rest of it. We aren't doing enough to protect them with many of our patients. And the only way that we can know to improve what we're doing is to look at the cause. We are looking at the symptoms of disease. We are not looking at the cause of disease when we are only looking at the damage or the inflammation or the bleeding. What we do know is specific microorganisms cause a dysbiosis. Yes, there are other factors that there too. I recognize that. But the one thing that we can have better control over than we ever have before is this group of microorganisms that control a large number, basically the whole microbiome relative to how it reacts with us, how our immune system reacts to this disease. And that's what these microorganisms are all about, is they create a dysfunctional immune system, and we have ways to control them, even eliminate them. And talk to Laura about this. Laura really is an expert in helping people understand how to do that. And yes, it involves adjunct therapies, and it will change from person to person. Gina doesn't do everything exactly the same way for every patient. I think we recognize that. But in periodontal therapy, we're trying to treat all diseases basically the same. And we have different technology, but that doesn't mean that we achieve an end result that is satisfactory for the immune system. And to add further fire to the future, I kind of thought some other things about this trial that I looked at on type 2 diabetes. This was a 35-year controlled trial looking at individuals that were treated for periodontal disease and followed them for 35 years. And if they had, and I've forgotten how many hundred patients, I'll present that at AOSH, but hundreds of patients. At the end of 35 years, they simply counted the number of people that had diabetes and the numbers that didn't have diabetes. And they found there was a direct correlation to the endpoint of periodontal therapy and the incidence of diabetes. So if you had greater than 20% of the bleeding 35 years ago, and you maintained that route, greater than 20% of bleeding, 37% of you had diabetes during that period of time, discounting all of the other risk factors. So knowing that, as a clinician, wouldn't you want to say, I want to achieve an endpoint that says, if I want to help a patient, I need less than 20% bleeding to make sure my patient doesn't end up with type 2 diabetes. That's just an example of how we can use the oral microbiome and these microorganisms to reduce them so that we are restoring the immune function. Now, Laura and I both, and Gina would all agree, and Whit too, that we want to do better than that. We actually would love to have no bleeding. By the way, the subject I'm going to be speaking of at AOSH this year is the greatest myth in periodontology. And you know what the greatest myth in periodontology is? It can't be cured.
Tom, that's the greatest myth in cardiology too.
Yes, yes, yes.
So we're not looking for and treating subclinical disease like Laura and I talk about all the time. That's why we're so excited when we get people in their teens, in their 20s, in their 30s, and why we start everybody on nitric oxide supplementation when they're 40 or 45, because once we see disease in the cath lab at the hospital in the vasculature of the heart, it's been going on for a long time. We could have turned it around much sooner. We could still turn it around at that point. They may need intervention, of course, at that point. But that's why this community has the opportunity to change healthcare, because we're not waiting. You bring them to the cath lab and put a stent in, or say they need bypass surgery. We want to look now as early as possible, collaborate on the causes of that to keep them from going down that path.
Absolutely. And in that same context there, and pardon me for over speaking, but I think this is such an important topic that we're talking about. And really, that's what this IDM community is about, bringing up questions and asking why. Why aren't we achieving, and why aren't we required to achieve an endpoint that's systemic as opposed to an endpoint that's just oral related? Why aren't we required to do that? As healthcare providers, we aren't required to do that based on, let's say, ethics. But I tell you, from my ethical standpoint of view, if I were seeing patients today, I would require myself to produce an endpoint better than what is required based on the clinical guidelines from the AAP or the European Federation or whoever, because we know better than that. And I would also add to that, particular point, that it is a process. It's something that you have to learn, and the more you learn, the more you use, the more you feel, the more you recognize that your treatment is not achieving an endpoint that it should achieve. And so then you shift gears. I oftentimes use the analogy, and Gina's my doctor, by the way, and she's guaranteed me that I'm going to live to 100 and I'll never have a heart attack or stroke. And we're all going to celebrate that in 20 years. So I've got 20 years left. And I may still be talking about the same topic in 20 years too. But anyway, long story short, that what I just want to make here is that this is such an exciting opportunity for all of us. We learn from you, and hopefully you learn some things from us. And asking these types of questions is critical. It's critical thinking. And we need critical thinking in all of our professions. So thank you, Whit. Thank you, Gina. Thank you, Laura, for leading these types of programs. And I'm excited about meeting all of you all that are on here tonight too.
Well, thank
Laura?
you, Tom. Yeah, go ahead. I just want to lead into some concepts we brought up for everyone to kind of grab their pen, pencil, maybe take down just a few notes from Dr. Neighbors, what he presented to us. Like, what was your maybe aha moment, a little takeaway? But for me, I kind of want to capture this mindset. Just got to present with Dr. Gina and our good friend Ann Rice, who's hopefully on tonight. If she's not there, I want to give a shout out to her. Is that we really talked about this dental confusion, because it's a mindset. We're very dentally confused as the providers, let alone our patients. And this is how we want to help inspire and fulfill you every day, that you can move from this kind of dental confusion that Dr. Neighbors was talking about to dental confidence, that you can be confident in your decision trees, in your decision making, in your treatment. So that's one concept I want you to write down. Where are you from confusion to confidence? Where do you think you lie on that? The second thing I'd like you to write down is to really capture, am I doing monotherapy? You've heard me say this before. We get so like monotherapy. I'm going to do the same thing, even if it's a bunch of things, but it's the same thing on every patient, and it should work. I call that dental insanity, by the way. But this monotherapy, to really thinking outside of the box. Thank you, Ann Rice, for that. We need to expand our box, make our box bigger, that we have combination therapy, that we really have different combinations for different situations. So if you haven't moved yet from monotherapy to what I call combination therapies, that's another concept I really want you to think about. And then I use the term meat suit. You heard Dr. Neighbors and Dr. Gina talking about this, about what's the root cause, what's going on a test, the test. I like to tell my patients, our first goal is to get the markers and the tests to look better. The body will follow. Most people have that backwards. They're getting their meat suit, working out, thinking they're going to look great on the outside and the inside's going to follow. We don't work that way cellularly or chemically. You know, a lot of people can be making their meat suit, their outside look good. And I call them skinny fat or heart attack skinny. I have all kinds of words, believe it or not, for how I name some of these people I see, whether at the gym or everywhere else. But cellularly inside on these tests, as you see this person on the right, look at the far right, look at all that red. We only had 3 green. And so I want you to take a hard look at that, because this individual, if you saw this person, you would say, clinically, they look great. They look healthy. Their BMI, right, looks great. They get on the scale, you do their height, their weight. Wow, they exercise. So again, but the inside does not match. And so we need to kind of flip that switch. Internally, we need to be looking at our patients first. Now, I'm not saying throw the baby out with the bathwater, but clinical presentation is only part of the story. Please write that down. Your clinical presentation is only part of the story. You could be being conned by what you see on the outside to what's really going on in the inside. So as a provider, we need to say, hey, I need to know what's going on the inside first, and then be looking to the clinical presentation second. And I tell my patients all the time, it's easy for me to put a weight loss plan and to start losing weight, right? And to get an exercise program, and we can start changing that outside. I know we want that to see, but the bigger thing is what's happening on the inside that can drastically have an impact on our lives that changes it in an instant of a snap of a finger. And so with this patient, we really worked on getting some of those numbers, as you can see in the green. So dental colleagues, I want to call out to you, what changed? What do we see from those crossover tests? Well, that MPO, that myeloperoxidase, we got to reduce that. So we know in the arterial wall, we're already decreasing that inflammation. Right? We know that the plaque 2 is still in a danger zone. Definitely move the right way. But what does that tell us dentally? From that second line right there, LP-PLA2 activity, we are not done dentally. We are a major player, and the major player to that is periodontal disease. So we need all our tests that we have in that crossover to make sure they're completed and our work is not done, no matter what this patient looks like. We have our, and you see Dr. Gina shaking her head because she's like, whoa, we're on fire and I need your help. And so we have work to do. Great, our CRP looks better. Great, our microalbumin looks better, but our ADMA is still yellow at 100. Remember, that's our inverse relation to nitric oxide. All my airway lovers, yes, your work is not done. We are very suspicious of this patient and have some airway work. So now we have perio work, it told us, that PLA2, our airway work needs to be done on ADMA. Love that we got our oxidized LDL. That's the most dangerous one. So we always want to get that oxidizing, right? We're rusting, oxidizing cells. I always like to make that correlation. That was huge improvement. Our F2 isoprostanes, we can see a good improvement. Cholesterol, again, we're dropping, we're moving in the right direction, but we still have some other things to work on. But I want you to see that there are 2 screaming out to us dentally that our work is not done. That plaque 2, where's our perio, where's our pathogens? We need that test to confirm that and know what the next best step is. And then our ADMA is right at 100. So we need to know what's going on with oxygenation, even though we started our nitric oxide therapy on this patient. So I just want you to see what jumps out on me. Obviously, when we first saw the before with the patient, we had to work on everything. Now you can see, we call it narrowing down. Okay, we're going to get down, down, down. Now we really need to focus in on these things that didn't get resolved. So maybe some notes there, some questions. I want you to see what jumps out at me. as this integrative system as we work together. It's really the system of us going back and forth and narrowing down so we can now be really personalized with our patient. Yes, Dr. Neighbors.
Oh, I think you brought up some amazing points there. And one is that in dentistry, we think that everything that we do should be perfect the first time because we failed when we were in school if it wasn't, right? We had to redo it. But medicine's not that way. Medicine's not that way. If you notice what Laura and Gina were saying is that this was a gradual process. This was a trending. The patient is trending more toward health today than they were when they started, but they still aren't at a healthy state compared to these markers that they're looking at there. Periodontal disease is just like that. Some of these patients have had these infections for years. And just because we do scanning and root planing or lasers or trays or whatever, and we get a second report that shows us that our treatment has not achieved the end result we're happy with, doesn't mean the test is bad. It just means that it's going to take longer for that patient to get where. So it's a trending process. So don't get in too big of a hurry and don't beat yourself up if your second test isn't perfect. Notice Gina and Laura not beating themselves up, or they wouldn't be here today if they gave up the first time they saw that their treatment wasn't perfect. The second thing that I want to say here is a great question, and that is, do you ever see by the way, pathogens is really what Laura's talking about relative to LPPLA2 and MPO and all of those markers, because we have to measure the pathogens to know whether or not those are the ones that are involved there, except in the case of subclinical endodontic disease, which I'm sure they're going to talk about also. But what I want to say, the question was, do you see some patients high in pathogens and no clinical signs of disease? And the answer to that is yes. It's like saying, do you see high LPPLA2 in people that haven't had heart attacks?
Every day. I think that's what we have to start to separate. That's why I said, clinical presentation is not the main story. Just like with this patient, looking at them and their physical appearance, the doctor would tell them to leave the office. And yet this person was getting ready, progressing to really what we would say to having an event. Now we're creating health. So I don't have a test to show the progression, but what I want to take away from what you're saying, Dr. Neighbors, is that instead of saying there's something wrong with the test, because that would be like Dr. Gina and I right now saying, oh, well, the plaque 2 is still high. There's something wrong with Cleveland Heart Labs. It's their fault my test isn't better. No, it makes us go back to the drawing board and say, what combination of therapy, what do we need to change in that? Do we need to increase something? Did we miss something? Like she said, we go back to the drawing board because, right, we're dealing with this individual patient. We can't just say we're going to do this same thing on every single person. No, what is their test actually telling us? And now what decisions do we need to make? And that's really important. Unfortunately, I do not have a test progressing, but I do have a test of before and after. And we wanted to show this because we shared this again in our recent RDH under one roof presentation, because this patient was present and did want her community to know, as a hygienist, this is what's possible. And she actually had to train another hygienist how to treat her. So I was like, telephone, right? I'm telling my patient who's the hygienist, who's going to go and now teach and make sure that provider, that hygienist, is giving her that exact care. So I do want you to see that this patient did want to do that GI protocol. A lot of our patients choose that because they're getting prepared for that antibiotic. I saw some questions around leakiness, right? We want to prepare for that. Especially if our patients have any issues, or we can see, as you can see on that, there already is leakiness going on. We want to do that. The second thing is really understanding, I can't stress this enough, biofilm disruption. This patient has no pockets. Just what you brought up. This is a hygienist who is like, I was going to say, clinical presentation is, I almost don't care. Right. Anyway, I don't even want to see a period chart because it like distorts your view almost of what's really there. Because look at this before test. Look at how high our FNTF, we're missing TD. We have a resistant pattern, that V. We have high PG, and this is one of our patients who's high risk now for cardiovascular disease or an event, and we need to squelch that as soon as possible. So the biofilm disruption was scaling and replaying. I think she ended up, because she told me she was healthy, we had 4s. And again, remember, our community is really distorted, very confused on this. We got to get into confidence around it, that, right, we need to be cleaning out those areas. And she also is a laser trainer. So who better than to be making sure she could get her own LVR done on her own mouth. We did choose the right antibiotics based on what was presented. Remember, when TD is missing, we have a couple choices, but this patient, actually, we did a GI. Remember, Dr. Pritchard, we ran the GI before and we knew she had E. coli. So I want you to hear me, because we could have chose naloxifloxacin, but me as the provider, now having that GI full-blown panel done and knowing how high her E. coli was, and she was having issues, we know one of the antibiotics for that in the GI is metronidazole. So all the more we wanted to choose that right antibiotic, and for at least those 14 days. Somebody asked about resistance. That is a hot topic for me, my favorite topic. Honestly, we're going to have some great things coming in IDM on our platform around that. But I did want to stay away from anything that would cause resistance. Remember, when you're missing a species, we can see we have an abnormal growth. Doesn't matter what test, there's abnormal growth. We need to stay away from those types of products. So one of our go-to products is Stella Life. It's because it doesn't cause that type of resistance. And so we needed healing. Somebody asked me on here, I saw, what can we use for life? My first question is going to ask you, why do you need something for life? I think we need to revisit that and have a whole study club around that, because we need to be asking, why should we be killing anything 99.9% of the time? Any microbiologist will tell you that's not healthy. How I want you to think about it is, if I was, constantly putting some type of antimicrobial on my skin, on my face, go ask your dermatologist. They will like freak out on you, because they want your healthy skin. It's our largest organ microbiome to be healthy. So if we need it, we need to use it. I asked, do we even need to use it on many of our patients? And Dr. Gina will vouch for that. I'll say, do I have signs and symptoms? Do I need help healing? Do I need to change that tissue, right? Do I need a faster way to get to that goal? Then I'm going to choose a product that can do that for me, has these healing properties, and I know isn't going to counteract through resistant properties. And then we have to choose the right probiotic. That was our next question. We base our probiotics on where they grow. Somebody asked, how do you know if you have a good probiotic? And again, that's probably a whole seminar. I would say go back to our last study club. We did talk quite a bit about that, but one of the safest ways, and Dr. Gina, please jump in, is to make sure it's GRAS like certified, because the FDA and things do not control probiotics. You can throw your own probiotic up on Amazon tomorrow. So we do need to be careful about that. That's why you see a lot of our products coming through the medical side. Dr. Gina had given that in her GI Gems. We talked about some of those products that we know have been tried and true and researched. Many of them do not have good research on the oral microbiome, because they are not grown and sourced there. Please write that down. That is a key point. We have to know which bacteria we're trying to fight. And so again, we have to have a test to know what bacteria is there, because that's going to be a determining factor in which probiotic you would use. So in this case, I wanted to go after, we always go after the most pathogenic. And that's why I chose that Pro Pro to shut down that PG. If we did not have PG, then I would have had to go after my TFNFN, and that would have been a completely different product, which could have been from our family of Stella Life. We have other ones that are those bliss strains as well, and prebiotics as well, which could also be from many that you know, your burst companies, BioGaia. But please go look at those studies that they're doing. Like you said, make sure that there are studies there that back that up. And then I like to always have my patients, after the antibiotics, they're not on the GI protocol during those 14 days. On day 15, they go back on our GI GEMS protocol, and that is to reheal and seal if any damage was done by those antibiotics. We want to do our due diligence. So I just want to spend a little time on here because this patient was a hygienist. I want to give her a call out because she is like, I'm following this to a T, right? Dr. Gina, please add in and look at her after. Yes, Dr. New is trying to tell you it doesn't have to be perfect, but I want to show you, for all the people who don't see perfect, this is possible. Like we said, periodontal disease, it's a myth that it can't be cured. We can cure it. She actually just did her 3rd test. I don't know if she's on tonight, but I want you to let you know, I will be posting her 3rd test in our next one. Anyone want to see it, or she wants to share in the chat, she just has FN. And so we are heading into our 6 months out, and that's curing periodontal disease. We know FN is a core species seen in both health and in disease, but she is not getting these pathogens back. So a lot of power in what we're doing here. And so we want to throw in the continuous glucose monitor, and I'm going to turn this over to you, Dr. Gina. It is a very at-home topic for me because I do have a type 1 diabetic in my home. So I eat, breathe, and sleep this. This is something we should all be learning about. And we're going to be talking more and more about how to capture this with our patients at the chair. So stay tuned for that, because there's some great upcoming information. But explain what we're looking at. And we always put a monitor on our patients.
Yeah, so the reason I wanted to show this is, first of all, it is the same patient, the dental hygienist that we just showed the clearing of the bacteria in her saliva in the previous slide. And as Laura said, we put a continuous glucose monitor on all our patients. And the baseline continuous glucose monitor that she sent us was this one is much improved. I'll just say that. In the future, we'll talk about it in more detail. But the main point I wanted to make about this is, with these interventions that we're recommending for our patients, we're highly interested in improving their insulin and glucose communication. You've heard me talk about it's like a continuum. Like when we're born, ideally, insulin and glucose communication is pristine. We want it to stay that way the rest of our life. But then we start moving towards this insulin resistance, then towards prediabetes, and then we end up with full-blown diabetes. And that process can go on for years before it's ever diagnosed. Now, talking about great targets and tools and measurements, Dr. Neighbors, we have great measurements and great ways to actually look for subclinical disease. We wouldn't even call it disease. We would call it subclinical problem with the way insulin and glucose are actually doing their job. And so the continuous glucose monitor is just one of those, a very powerful tool. As Laura said, we have others. But what I wanted to point out on this is she has an absolutely pristine continuous glucose monitor result, because what you want to see, and you don't hardly ever see it, we hardly ever see it in our practice. Even in patients who are walking around, they look like they might even be an athlete. We've seen on people that are athletic, they might be vegan, they might be paleo, they might be hanging their confidence, if you will, they're kind of cardiac confused, and they think they're cardiac confident because of whatever. I work out, my BMI is such and such, and look, my muscles are getting bigger, or whatever. I'm maintaining my muscle mass. All of that's important. But we find peaks and valleys in the glucose result on the continuous glucose monitor. And so at the bottom, you'll see that even the continuous glucose monitor gives this broad range between 70 and 180. But when we see athletes that, for example, drink a pre-workout drink, and they don't even think about what's in it, they will spike up sometimes to 180. And do you know, even the American Diabetes Association says if you ever get a one-time blood sugar reading of 200, that person has diabetes. So we see that in people that are walking around looking and feeling healthy all the time. But what our goal is to look like this person here, where it's almost flatline. Now, in cardiology, you don't want to be flatline, obviously. In diabetes, you want to be flatline, meaning you want this to be gentle rolling hills between 70 and 120. And she will occasionally go high. This is her actual readings. And then the dark blue line is her average. So her average glucose was 96 over the 2-week period that she wore this continuous glucose monitor, with a glucose variability of 10.3%, which is fantastic. This person is not headed towards diabetes. They do not have insulin resistance. And we do pair this with other tests too, like on the Cleveland or the Boston, we're looking at insulin levels, we're looking at hemoglobin A1C, we're looking at triglyceride levels, looking at liver function tests, looking at uric acid. It's a puzzle, but we can get a really good understanding of where someone is in terms of not even diabetes, but headed towards diabetes. And so if this person hadn't gotten rid of those pathogens, just as Laura and Dr. Neighbors have talked about up till now, this would not continue to look this great, because we've talked about this circular or bidirectional relationship between periodontal disease. Even if they don't look that bad, maybe they're not bleeding and they just have some fours, but with pathogens like she had, this would be impossible to maintain. We've seen enough of these to know. And the research supports that your insulin and glucose communication will ultimately start to suffer. What else would you say about this, Laura?
Well, that's such a good predictor. We talk about, right, Dr. Nurse, predicting, preventing, Dr. Gina, that's all what we're doing. And this, again, is a great way that I can see predictive value, that not only with what I'm continuing to test on the pathogens, continue the blood work, but here just on her glucose readings, I continue to see that, right, in that bidirectional relationship, that she's helping us be able to sustain that in her bloodstream. So that is huge for us long term. The other thing I want to say about this is when we saw the patient in person, I almost didn't recognize her. Right, I turned to Dr. and was like, oh my God, I did not recognize her. And she was like, I know. Okay, why? Because her outside is starting to follow her inside, and it's dramatically changing her skin tone, her texture, her face. I said the way, her confidence, like knowing, it was unbelievable. And so I want to say that to you, that when we work on the inside, I said, look what naturally starts to happen. We've got to flip again that switch and understand that. But this is a huge part of really in our integration, that we understand this bidirectional relationship. We're talking about it. It's more than telling somebody not to eat sugar because they're going to get a cavity. This is truly about, you know, what that whole relationship with insulin resistance really means and how we can help our patients. So just wanted to show that as we were looking at our patient. And so we want to talk about just solving and breaking down some of these barriers in oral systemic care. We want to invite people to become a fellow. And Whit, I'm going to pull you back into this, is because this really has been him as our founder and CEO of where we want to go, what we want to do in our community. And so we want to introduce this to you and kind of hear maybe some of the barriers or things that you're having issues with, because we know that it can be kind of feeling like you are in confusion, and we want to help you really take that transformation to confidence and how we want to help you get there. So we're calling this our OASIS program, and I want you to write it down because it's an acronym. So write down OASIS, because we want you to be able to truly integrate the oral and systemic integration system into your practice. This is what we're talking about. How do you actually integrate this into what you're doing each and every day? How we can help you start that. And so we've created this program that we want to start to introduce you to help you become a fellow here with us. So Whit, join us. What would you like to say before I continue on and kind of talk about the program? But this has been just a huge really, I'm going to say, mission of yours to help our colleagues be able to start to accomplish this.
Yeah, some of our recent conversations have really helped us to clarify how we can together have goals that we can achieve that are measurable and, definitive. So in the last couple of months, for example, we've completed, as you've seen, now available online, our foundation seminar, which really outlines all about inflammation, and then the 3 pillars of IDM, which is inflammation and infection, orally and systemically, airway, breathing, and sleep disorders, and then TMD and malocclusion, and how that connects back to the other 2 and how they're all linked together. So that's our building the foundation, and that's a seminar that's now available online. That was a course that we were doing just simply live in the past, but now is available. Then we have 2 what we're calling essentials seminars, or courses, courses that are online. And the first one is the essentials of inflammation and infection, and that has been completed and now is available online. And essentials of airway, breathing, and sleep disorders, that'll be coming out soon. And then the next step in this OASIS program would be the Advanced Inflammation and Infection Workshop. And so that's coming up in October here in St. Petersburg on October 20th and 21st. And so that's something you're going to want to sign up for ASAP, because actually it's filling up pretty quickly. We may have to tentatively set up another one in the near future. But in that, we will be spending 2 full days just going over cases, interacting with each other, role playing, getting this into your hands in confidence that you can do at the office with your patients. And then on top of those 3 online courses and 1 live workshop, we're also going to add to that a 90 days of coaching through Zoom get-togethers every other week that would give you the opportunity to do questions and answers, go over cases, present things that you're seeing, both successes and concerns that you have. And we bring that together to complete the OASIS kind of basic program. But at the end of that series, you would receive a fellowship status in IDM Scholar Society. Then beyond that, for some, if you really want to take it further, then what we're going to do is, the thing is, our objective is this: we want to change the healthcare of our nation, and we want to do it through dentistry and medicine working together. And we want to have the ability to collaborate all over the United States and have referrals all over the United States, in every city and every state, of people that are competent to engage in these things. And so just even going through the OASIS program and completing the fellowship status does not mean, I'm just going to be totally honest, that we would want to refer a patient to you and say that you're an expert now at doing anything. And I know that all too well through being involved in education for 40 years. And so what we want to provide is another level, and a very advanced level, that would be going forward to become a certified health coach in this integrative medicine world. And so that would involve another opportunity, but also the involvement of doing online discussions together, of having homework, of having reading assignments, of having to go back to your office and do so many tests and so many treatments and so many outcomes, and reporting those, and even talking about that in these meetings, where we would be evaluating and working with those that want to become a coach that would be certified through our organization, through our academy, to do that and be able to talk about that in your community and in your practice. And so that would be the next level up that we're developing and we'll be sharing with you. But you can talk about, Gina and Laura, how we want to roll this out if you'd like.
Go ahead, Laura. This tells the next steps. We're going to send you an email, obviously very soon, within the next week, about how you can join the OASIS program, exactly what that looks like in more detail. And then we want to have another webinar or a webinar on August the 16th to answer questions, to go through it thoroughly so you can understand what you're getting into. And then we want to and make sure you've got a spot at the workshop, because if not, as Whit said, we're going to add a second date to have a second workshop because it's already starting to fill up. And then we want to celebrate with you at the symposium when you get your fellowship status. I think that's going to be such great fun, and talk about next steps. So our goal is for you to become confident in having these conversations, not only with your patients, but with your medical colleagues if you're on the dental side of the equation, and with your dental colleagues if you're on the medical side of the equation. We really want to drive this conversation and mastery of these concepts forward. And so I hope many of you, if not all of you, will participate in this so that we can change the one patient that's sitting in front of us and the health of the nation, as Whit said. It's up to this group to do it.
We'll talk about this more on August 16th, but we want to make this something that is very desirable for you to do. And we're committed to the movement and for us doing this together. So we're analyzing this right now, how we can bundle these courses together. And for those that want to go through the whole curriculum, that we can give you some type of discount for that, even beyond the 10% for being a member of the study club. Or if a doctor and a hygienist, for example, want to do it together, then we'll bundle that together so that we can make it something that you really can do and want to do. We're just really excited because our goal is to have hundreds of people who are going through and becoming established, where we can put on our website a map of the United States and put pins where you are and say, these are people that have been certified through going through extensive learning that are now qualified for you to work with a physician from MDVIP that's looking for somebody in Ohio to work with that understands salivary testing and non-surgical perio and the oral systemic connection, because they realize that it's super important. Laura and Gina have been working with MDVIP. It has over 1,000 offices in the United States of physicians, with Alan Reisinger, who's their educational director, and they're going in and doing workshops on the oral connection and on salivary testing and on oral pathogens. And these physicians are very interested, but they don't have anybody to refer to that's within 1,000 miles of them, and we don't either. And so that's part of our objective, is to change the landscape of medicine and dentistry. And so we're the only group right now together that are really attacking this problem and developing the solutions that can be integrated together in such a way that can really truly change the landscape of healthcare, and specifically as it relates to inflammation, orally and systemically. So we want you on board. We're going to do everything we can to just make this possible for you and to make it happen so that we can grow in this together, as we're learning too, grow in this together and make it something that is very exciting and truly a revolution. So please join us for the August 16th webinar, but also there'll be things posted online, and you can go to our website and we'll be announcing all these things multiple times. But we're very excited about it. We feel like we've got real clarity now on specifically what our goals are for each other and how we can do that. And we do, as I hope you are clear now, see this as our calling, much more than a business model. This is our calling, and we want to share and provide opportunities for each other.
Yes, so I guess we'll open up to some questions. I do want to throw a challenge out there for anyone who's just dental. I know we say it all the time, but You have an MD VIP, you have a Vaildanine, you have a functional medicine, you have a chiropractor, you have an endocrinologist, you have a primary care, you have a nurse practitioner, maybe practicing on her own. These people are in your community, in your backyard. Love for you to be able to say to them, hey, let's do this program together, because I truly want to integrate this into my practice. And who better to come than to walk side by side, have these types of conversations, because it's going to be a safe community. Like we said, it's going to be an exclusive community for those people. That way, I say there's that confusion, and sometimes I say it's because we're a little scared. There's a little fear underneath sometimes of what we don't know. We just don't know what we don't know. And so we want to create this completely safe zone to be inspired, to be uplifted, to be supported, to kind of wash those fears and barriers away, that we can actually walk through those together as a community, because you are not alone. And so I'm going to throw that challenge out there. I'm going to say I was pretty lucky. I had that Dr. Gina's like reach out to me in the world, but most people don't know that you are this amazing hygienist. And I do want to give a shout out to my hygienists out there that are doing this and are just so diligently every day down in the mouth. My dentist too. Let's lock arms and let's make a difference, because it is completely possible. And we're here to help you every step.
I'd like to finish up just with one final comment myself, if that's okay with.
Sure.
I've been a big follower of Dr. Leroy Hood. Dr. Hood is both a doctor of medicine. He's also a PhD in immunology, and he's written a lot of articles. I've checked him out, Leroy Hood, MD, PhD. He wrote an article back in 2010 with one of his colleagues, and it was called The Future of Medicine. And we are practicing a pattern very similar to what he has suggested. And that's basically collaborative medicine, where we share information, we teach each other, and we learn from each other. But he simplified the whole concept of the future of medicine around the 4 Ps. P as in Paul. And if any of you ever heard me speak over the past 5 or 10 years, you've heard the 4 Ps, because they are so important. And what he is saying is the future of medicine is, first of all, we have to predict disease. Secondly, if we can predict it, we can prevent it. So that's the second P. The third is, if someone's already sick, then we have to personalize therapy in order to achieve end goals that are consistent with what the future of medicine holds for us. In Gina's case, it's preventing people from dying from heart attack and stroke. If it's Laura or myself or Victor or Mike or whoever, if we're treating periodontal disease, it's the contribution that we make to help prevent people from ending up with these diseases that lead to heart attack and stroke and dementia and so forth. And then the last, so we've got predict, prevent, personalize is participatory. Participatory, meaning that our patient has to become a partner with us, and they have to be able to follow instructions. They have to be compliant. They have to do the things that we suggest in order for us to achieve an end result. So with that, I would suggest that the IDM Society is really just what Laura Hood has been talking about for the past 22 years, and that is that's what we're trying to do. That's what salivary testing is about. In other words, let's test before they have disease.
Yeah.
Right? And let's make testing, whatever our job is, wherever our focus is, a routine part of our examination on healthy people.
Mm-hmm.
Before they have disease. Make it just in dentistry. We use 3D cone beams because 3D images are so much better than 2-dimensional images, and we know they work. CT scans are better than what we did in the past. And I oftentimes say it's not what we do see that's important, it's what we can't see that's important. And so in dentistry, without a salivary test, we have no idea of what the dysbiosis really is. And it's different from person to person. So with that, I just want to compliment, first of all, Whit for having the idea of bringing this together. He spent years and months and hours and so forth to put it together. And then we have Gina and Laura helping him organize and make this thing run. I just happen to be a bystander that loved the topic, but you are really what's going to make this thing work. It's your patients that we want to affect. We want to affect you, but it's really your patients that we see that are going to benefit. And each one of you, start with yourself.
Mhm.
When I first saw Brad and Amy, I said, that's for me. I was 67 years old at that point in time, and my vascular age was 65. I'm 80 now, my vascular age is 61. So I've aged 17 years, or 13 years, but my vascular age has become younger. So is it possible by doing what Gina and Laura and Whit are doing that we can actually live longer and healthier and enjoy our life much longer without disease? So start with yourself.
Mhm.
That's what I would end up by saying.
Yeah, agree with that. Well, it's time to say goodnight. Thank you all for being here with us and for learning together with us side by side. We're so excited about the future. I'm just so thrilled to the community that's forming, and we're going to form great, strong bonds through the years. And I hope we're all going to live long enough to see some huge changes in healthcare and be able to look back and think about that we were right there on the front lines when it all started, when no one thought it really could happen, but and 1% of us were talking about these things, but it should and it can and it will. And I thank you for your devotion and commitment to what we're talking about and implementing it personally and in your practice. So we'll be in touch. Please look for our emails and communications, and we'll be seeing you again soon in 2 months for our next study club meeting. So until then, God bless. Thanks so much for being with us. Thanks, Gina and Laura and Tom and everybody for being with us. Night.